So because I'm not the smartest person in the world, I just realized I'm always asking y'all to, identify the rhythm before I go on. But then I just realized as I'm uploading these to YouTube that you can just see it in the name of the video because I keep naming them after the rhythm. So yeah, if you've been guessing, then good job, I guess. If you've been wondering why I'm doing that, I guess you just got your answer because I knew doing this and wasn't thinking that I would name them all after the rhythm, but it didn't really see how else I would name them. So anyway, so if you did look over this one, hopefully you figured out what it is. If you didn't, and you're just looking at the video title, then guess what? You still made it. Doesn't matter how you got there, right? All sorts of different paths up the top of the mountain, but we can all agree that the view looks amazing, regardless of how we got up there. So yeah, this is ventricular tachycardia. And you can see that what's happening here, so last one we just finished talking about was ventricular fibrillation. Those looked, or that I should say, looked like kind of like a wavy, like quivering line. This, you can see the magnitude is so much higher. And that's because the difference here is that what's happening is instead of having that quivering that I was saying before, where like the ventricle, again, this is my ventricle I'm doing, it's like instead of quivering, it's giving contractions, but they're too fast, hence the tachycardia. And what's worse, well, I don't know which one's worse, I guess, but they're too fast, first off, and they're not syncing up or pairing up with an atrial contraction or a P wave. So going back to this, and this ties in with something I mentioned in that first video, there may not be P waves happening here, but there might be. And the reason for that is the magnitude of these, they're not really QRSs, they are, but like they kind of don't look like they should. It's so much greater that any P waves that might be happening, they're not going to be picked up by the leads because again, this is just overriding them. So there might be P waves happening, but you're not going to see them. You're just going to see this. And again, it's because this is the magnitude is like so much greater electrically. So basically it's bad because one, when the ventricles beat too fast, the bad thing there, well, there's a lot of bad stuff, but one of the big bad things is that they're not having enough time to fill up and actually give you a nice good beat. So that means that like your heart is working harder for less results, right? It's just it's like, if you're trying to do as many squats as you can, but as you're doing the squats, you're like, I don't know, you got weights in your arms going up and down at the same time. Like you're expending way more energy when you're not actually, and again, if all you want to do is squats, all we want the heart to do is pump blood. If it's not pumping blood efficiently, that's really bad. So if it's using more energy to pump less blood, that's like really, really bad, right? Also because it's not pairing up with a P wave, it means that they might not be filling at all because the atria has to pump for the ventricle to fill, right? So it's just very bad. And then again, over a long time, it's going to exhaust the cardiac muscles. So this can lead to then ventricular fibrillation or asystole. A lot of these bad dysrhythmias, they can lead into each other, right? Because if you have a ventricular tachycardia that's happening for a prolonged period that isn't addressed, then effectively what can happen is the heart gets exhausted, and then it starts to go into ventricular fibrillation and then asystole. So another thing is that in this case, when you have ventricular tachycardia, there's electrical impulses occurring in the ventricle, right? So in other words, the ventricle is like pacing itself. So again, there might be P waves. You might still have the SA node firing, but the ventricles, for whatever reason, there's a lot of different potential causes, but for whatever reason, they're not syncing up, and so they're kind of starting their own electrical activity on their own. They're going rogue. They're a rogue agent and they're doing their own thing. So sometimes it'll sync up, maybe if there's P waves happening, but if not, yeah, they're doing their own thing and they're not coordinating with the atria at all. So the electrical impulse is originating in the ventricles. They'll have a pulse. Like they might have a pulse. It kind of depends on some things, but they might have a pulse, but it's not real perfusion because again, when those ventricles beat, they're not really doing a good job of pumping blood. So that's why I say there might be a pulse. And actually, you can see this on some of these rhythms. When you have ventricular rhythms, so usually when we say like a ventricular rhythm, that means that the rhythm is it's originating in the ventricle, that the ventricle is pacing itself in some way. When we have ventricular rhythms, if you were to place a patient, let's say they've got an EKG running or a telestrip, like whatever that's monitoring their heart rhythm, and then you had them, let's say, on a pulse oximeter, so on their little finger or earlobe or wherever you're putting it, measuring their pulse and their O2 sats. What you can sometimes see in some ventricular rhythms is the heart rate is going to be maybe high, it could be low too. It just depends on the rhythm. Like if you had PVCs, you might have, like bradycardia with PVCs or something. But usually, yeah, like with this ventricular tachycardia, the cardiac monitor is going to be picking up like really fast heart rate. It's going to be like 100, or more. But if you were to look at the pulse oximeter, it might be 0. And again, it's because the pulse oximeter isn't measuring the heart beating, it's measuring the perfusion. It's like on the fingertip usually, and it's feeling like, okay, every time I get oxygenated blood to this area, I'm counting that as a heartbeat, right? Well, in this case, the pulse could be super high, or the heart rate could be super high, but you're not really getting perfusion in the extremities as a result. So again, don't want to spend too much time on that, but just kind of explaining again how these monitors work and why you might sometimes see things. And again, just understanding like what is actually happening in the heart when you see this rhythm. It's not enough to just know, okay, this is ventricular tachycardia. It's like, well, what's actually happening? What does that mean for the patient? So yeah, and obviously this is life-threatening. I don't probably need to say that, but yeah, I'll just say it anyway. So what do we do? Again, if there's no pulse and if they're not breathing, CPR. If they're breathing but they don't have a pulse, then you just do the cardio part of the cardiopulmonary resuscitation, just the C part of the CPR. And I guess also the R, just not the P. And this is another type of rhythm that if they have it, we will defibrillate. Medications. So similar to ventricular fibrillation, amiodarone and lidocaine are used. Beta blockers and calcium channel blockers also might be used, especially if a patient has a history of this. Some of these might be used long term. Really, any of these could be used long term. It's just beta blockers and calcium channel blockers tend to be like first line drugs we use for heart disorders or like heart failure, things like that. These are going to hopefully help slow down the heart, right, and make it beat more forcefully with each contraction. So again, it's trying to counteract that tachycardia and hopefully help kind of like basically it's to kind of tell the heart to like, all right, chill out, like just calm down a little bit. Get your stuff together. And then catheter ablation might also be used. Sorry for the bad image crop, but this is another, even though it says torsades de pointe and it looks like it should be a new rhythm. I'm including it as I talk about ventricular tachycardia because torsades de pointe is like it's a form of ventricular tachycardia, and I'm probably butchering the pronunciation because I don't speak French. My girlfriend does, or some French, and she also speaks some German and some Gujarati and some Spanish and a whole lot of English and probably some other languages, but I'm not so worldly. I'm confined to the swamps of north central Florida, so I just know English and not even that very well. So yeah, torsades de pointe, it's ventricular tachycardia. I'll get away from talking about my lack of knowledge more into the actual rhythm. It looks, if you notice, it like kind of looks like ventricular tachycardia, but it kind of like comes in and out. It has like these points where it kind of almost looks closer to ventricular fibrillation, maybe. And the magnitude of the rhythm, or the voltage, I should say, like it gets higher and lower. It's like starts out high and then it kind of like is starting to squeeze and it might get high again or something. This is a form of ventricular tachycardia. It's a very similar treatment as other forms of ventricular tachycardia. However, one difference is that the cause usually for this, as far as I'm aware, I don't think there's any other causes, but please correct me if I'm wrong. The cause for this is usually electrolyte imbalances. And so for that reason, magnesium sulfate is considered like the first thing you want to do if you see this. Possibly potassium, so potassium, probably potassium chloride or something. So electrolyte infusions, because these are usually caused by low magnesium or low potassium. So electrolyte imbalances. So maybe not, but as far as I'm aware, this is mainly the cause. So we want to do all those other treatments are still viable, but this is like the first thing we want to do because this is what's likely causing the problem in the first place. And obviously we want to fix what's causing the problem first. So then to avoid the problem of me not of me giving away the answer in the video title, yeah, this is the next one we're going to go over. So if you want to take a look at it for a second, this one's maybe a little more challenging. It's kind of hard to recognize. Well, you'll notice it. You might see some similarities to like the ventricular tachycardia we just went over. But yeah, we'll talk about this one in the next video. So yeah, that's it for ventricular tachycardia.